Today we are having a webinar to discuss a study one of our colleagues has conducted among university students on knowledge, attitudes, and practices on sexual and reproductive health issues at the University of Nairobi. So on the panel, we have Dr. Dismas Ongore, who is a public health physician and lecturer, senior lecturer at the Department of Public and Global Health, University of Nairobi. And his main focus is disease prevention and control. Of course, Dr. Ongore is a medical practitioner, graduated from the University of Nairobi and has a Master's of Public Health from the same university. And he also has a PhD in tropical medicine from Liverpool School of Tropical Medicine, University of Liverpool. He has a wide experience in public health and has formerly worked as a consultant epidemiologist with WHO, supporting the government of Eritrea. And he, of course, he has over 40 years experience working and teaching at the School of Public Health, now Department of Public and Global Health, University of Nairobi. So Dr. Ongore will be making his presentation today. And on the panel, we'll also have Dr. Carol Odula Obonyo, is a reproductive health specialist with over 20 years experience in our field with a wide international exposure. She is a senior medical specialist based at the University of Nairobi Health Services, Obstetric and the Gynecology Department. And I think the topic is a relevant issue to her because it's something that she sees on a daily basis. So we hope to learn a lot from her. She has successfully served in various boards, including the Kenya Obstetrical and Gynecological Society COGS, as well as the Kenya Medical Women's Association in the recent past. So Dr. Odula Obonyo served as a national focal person for the International Federation of Gynecology and Obstetrics, FIGO, an initiative on the prevention of unsafe abortion, as well as COGS for the Reproductive Health Alliance. And she's the immediate past chair of the Coalition on Violence Against Women, COWAW, a local NGO. She also serves on the board of Maristops Kenya and Population Council, where she offers technical advice. And she's the chair of the Kenya Medical Association's Nairobi division and also does some charity work with the Rotary. She's a chartered member of the Rotary Club of Lavington, Gioni, where she serves as the Sergeant of Arms. So Dr. Ongore, please welcome. The floor is yours.
Yes. Thank you. Thank you very much, Dr. Godia, for that introduction. As she has said, I'm going to share with you some of our findings on a study on knowledge, attitudes, and practices on sexual and reproductive health issues of students at the University of Nairobi. As a way of introduction, we know that within the framework of WHO's definition of health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, reproductive health addresses the reproductive processes, functions, and systems at all stages of life. The right to reproductive health has been endorsed and strengthened in successive international forums, particularly at the 1994 conference, ICPD conference in Cairo, at the Fourth World Conference in Beijing in 1995, and World Summit for Social Development, Copenhagen, 1995. The critical importance of reproductive health to development has been acknowledged at the highest level, notably UNFPA during the World Summit 2005, fully committed to mobilizing support and scaling up efforts to make reproductive health for all a reality by 2015. Again, as we know, many young people approach adulthood faced with conflicting and confusing messages about sexuality and gender, often exacerbated by embarrassment, silence, and disapproval of open discussions of sexual matters by adults, including parents and teachers, at the very time when it is most needed. Access to structured, comprehensive sexual education among young people 15 to 24 years of age is one of the known ways of addressing adverse reproductive health outcomes. And lack of comprehensive sexual education may increase among young people risk of sexually transmitted infections, early pregnancy, and unsafe abortion, which is likely to continue if urgent remedial action is not taken. So that was the background to our study. And our main objective was to investigate factors associated with the occurrence of unwanted pregnancies and uptake of sexual and reproductive health information and services. The study employed a cross-sectional descriptive design involving mainly qualitative data collection methods, including focus group discussions targeting students. The FGDs were composed of 8 to 12 participants for each FGD, with the year of study of the student being taken in consideration when forming the groups for discussion. Both male and female students were involved in the study where applicable. The study targeted all the 6 campuses of the University of Nairobi, located in Nairobi, scattered all over Nairobi city, focusing on students 19 to 24 years in session at the time of the study. In total, 6 FGDs were conducted, 3 mixed and 3 for female students only. Now, several issues that affect young students in the University of Nairobi were mentioned. Generally, this included common cold, UTIs, KBs, bedbugs, alcohol and drug abuse, as well as STIs and HIV/AIDS. Unwanted pregnancy were apparently quite common, shown by some of the responses, very common depending on behavior of the students. It appears pregnancy was more common amongst older students than fresh ones, as shown by a response from a first-year lady. As first years, we have hardly been here for so long, so it's hard for us to know whether there are many cases of pregnancy. Probably there are, but these have not reached us as first years. Reasons for unwanted pregnancies were varied, and as one male student put it, I think at this time, most of us are at the peak of puberty and are very active as far as sexual matters are concerned. A female student, however, remarked, it's ignorance and carelessness, as they know if they engage in sexual activities, something might happen, but they just ignore it. Alcohol and substance abuse was also mentioned. I say drugs are also a cause, because when someone is under the influence of drugs, they don't know what they're doing, so they're susceptible to being pushed into doing anything other than another student. On the status of abortions, the feeling was that this one common, very common laughter. On a magnitude of 1 to 10, the cases I've heard of 6 out of 10 will procure an abortion. The female student added, I can't be certain we hear 3 out of 10. Methods used to terminate unwanted pregnancies. These were diverse and varied methods were mentioned, with some sounding rather bizarre. I've heard of drinking concentrated tea leaves accompanied by laughter. I've also heard of drinking concentrated juice as well as jik, said another. Yet another added, some go to doctors, gynecologists who prescribe for you some pills, but not over the counter. So you need a doctor's prescription and they give you some drugs, you just take it and the fetus is expelled. Reasons why ladies opt to get rid of the pregnancies. The predominant themes were victimization, peer pressure, stigmatization, attitudes from parents, poverty, as well as academic pressure. On victimization, a student said, as a young girl or lady, your friends, all those people around you are not pregnant, then you are pregnant, then you will just be isolated. So you are like, why I should carry a baby when I can also take the abortion and be fine? Yet another added, being treated as an outcast, especially by your inner circle of friends who may leave you at that time and may advise you to abort, and if you refuse, they will not support you. On condemnation, the student said, I think there's a lot of condemnation by society around you. Your parents and the village, when they hear you're pregnant, so you don't want to live with that pregnancy because of just that fear. Another student remarked, your parents will look down upon you. Maybe you wasted their money, they took you to school, and you are ending up pregnant. So it is just because of fear. On poverty, a female respondent remarked, poverty will make you frustrated and you will have sex for money and get pregnant. On academic pressure, the student added, they realize they'll waste a lot of time. So they need like one semester to give birth, nurse the baby for 3 or 4 months, so they abort. Information on reproductive health and abortion. It was the general feeling that some degree of information should be availed. A very interesting observation. I think the best information should be on sexuality, not on abortion. A female student added, the information should be on use of protection always and going for family planning. Another lady added, the information necessary for the students is concerning safe sex and safe methods of engaging in sex and avoiding pregnancies. On where to get information on reproductive health, including safe abortion, several views were advanced. One student said, from a qualified doctor you trust. Another student added, you can look for someone who has done it successfully and maybe she can help you with the name of a doctor. Another female student suggested, also the school gynae should be readily available. Further, where to get information on reproductive health, including safe abortion, the university and the university clinic was also mentioned as one lady put it. The staff from the clinic, if they are facilitated, then they look for a venue. Academic sources were also mentioned. In school, we have a course on HIV/AIDS, and it has plenty of information and can be used. I'll call you later, please. Providing sexual and reproductive health information and support to students. Several views were advanced on who in the university should be in the best position to provide sexual and reproductive health information and support to students. Fellow students and student leaders was mentioned. As a male student put it, the best placed are the students themselves, horizontal communication compared to vertical information. This was reinforced by a female student. I think fellow students, in particular the student leaders, because the student leaders are the ones the students themselves have chosen, so they tend to trust them more. Lecturers were also cautiously suggested. Maybe that lady lecturer who can talk about lady issues and you are comfortable with, and who in addition is more motherly and more experienced. We also looked at barriers to receiving information. And several barriers to receiving the information were also mentioned. As one student put it, we fear going to the clinic because the nurses ask too many questions. Another student added, the nurses there at the student clinic have a bad attitude. You go there like you want a pregnancy test. It's like you have done a mistake that has never been done before. And it's like you are damaged goods. So their attitude is really a put off. An emerging theme was that the staff working in the school clinic could not be trusted because they were likely to be judgmental with the attendant consequences. As a female student put it, maybe you don't want to make it public as you want to terminate it, and no one should know. So when you go to the clinic, and the nurse might make a follow-up, and you have already terminated, and you are like, what am I going to say? Additional barriers, another others. Nurses talk about those issues, and the next thing you hear from someone whom you didn't even talk to, and you hear from somewhere else that you are pregnant when you didn't talk to that person. There was the added fear that information would leak out to her colleagues and lecturers in particular, and they might be discontinued, as one lady put it. Next time they apply for accommodation, they won't get a room as the school assumes you have deferred. Another added, some are afraid of being expelled from the university halls of residence, and the rent outside is very high. So from the aforesaid, we made several recommendations. In order to address the health issues facing students, there may be a need for the University Health Service to carry out an assessment of the health problems facing the students and structure the health services to be responsive to the problems. Appropriate measures should be put in place to address factors contributing to unwanted pregnancies among students. In addition, multidisciplinary fora should be created to address sexual and reproductive health matters with students, include issues around puberty, sexual development, alcohol and substance abuse, peer pressure, irresponsible sexual behavior, and abortion. Information on sexual and reproductive health should be available in the school website or portal through pamphlets and social media. A conducive, non-judgmental environment with adequate counseling and pregnancy testing services should be created for students with unwanted pregnancy to discuss issues about their pregnancy in an open and supportive university. Finally, a retraining and reorientation of the university health workers, in particular the nurses, should be done periodically to eliminate barriers to utilization of health services for pregnancy and other reproductive health issues. And here is a list of key references, a few key references. This study was actually published in the May 21 East Africa Medical Journal, and that is the volume 92, 5 May 21. So thank you very much for your attention. Over to you, Dr. Godia.
So thank you so much, Dr. Ngore, for that elaborate presentation. I think the presentation has been self-explanatory on what you are trying to find out. So I think at this time, I would invite Carol to make a comment before we go to the question and answer session.
Thank you very much, Dr. Godia. Dr. Ngore, my senior, you have really brought out issues that we're grappling with. Those are real issues. What are the real public health implications? So Dr. Ngore, what we're looking at is the environment, isn't it? We're looking at a restrictive environment to provision of safe care in this whole country as a whole, not just the University of Nairobi Health Services. The real issues you bring up are telling us about the wider issues, and those are the public health implications in a restrictive environment. Just to go back a bit, if I just go back to history, whereby in Africa, there is an old adage that every pregnant woman has one foot in the grave. And this rings true up to now, because in my grandmother's day and age, they prayed for their daughters who were pregnant to be separated at childbirth, and both mother and baby came back home, because many a times that did not happen. No wonder our maternal mortality is so high. In this part of the world, sub-Saharan Africa, further research shows that it is 32 to 35% unsafe abortion contributes to our maternal mortality by 32 to 35%. Who are the contributors of these big numbers? It is our young ladies, our young people at university setting, at high school setting, who do not have the information to make informed choices. But if you look at the legal environment, just to go back a bit, the Kenyan legal environment, the Penal Code, Articles 158, 159, as well as 160, and the criminalization of abortion is not in tandem with the Constitution that we celebrated in 2010, August 27th. The Constitution was a wonderful thing that we celebrated, and we really hope that the environment, the restrictive environment, will be opened up. That's not the case, as the Penal Code is still where it is. We also have our national guidelines on the management of sexual violence in Kenya, the 3rd edition, 2014. I'm surprised the young people who Dr. Ngore spoke to did not say that the University Health Services is able to manage victims or victors of sexual violence. We do have the capacity, and the guidelines are there from the ministry. We also have national guidelines on quality of sexual care as well as perinatal care. There's a Ministry of Health circular on post-abortion care, June 2013. Doctors and nurses are bound, even clinical officers, we are bound by code and conduct of ethics and discipline, and including for nurses the scope of practice in this country. Looking at the regional environment, there's a protocol on the African Charter on Human and People's Rights, on the rights of women in Africa. They widely call it the Maputo Protocol. That allows us to use medication abortion to help women, young ladies, students who come to us in time, widely called the Maputo Protocol. Kenya sets a bit of reservation on it, but people who understand the situation are able to work with this environment. The WHO, which Dr. Ngore referred to, have given us the technical and policy guidance, and this was updated in 2012, as well as WHO guidelines on health worker roles in providing a safe abortion care, as well as post-abortion contraception. When we talk to young people about family planning, they ask me, what is family planning? So I tell them, let's use a better word, which is contraception, to prevent conception. Many of them don't even understand how sleeping or meeting with a man can result in pregnancy, including students who are studying medicine and sciences in their earlier years. Let me talk one more further thing about International Federation of Gynecology and Obstetrics Initiative on the Prevention of Unsafe Abortion. We talk about conscientious objection. What is conscientious objection? A person who's trained to carry out a safe termination can conscientiously object to say, no, I am not able to. But in cases of an emergency, there's no objection. You must carry out this safe procedure. Otherwise, if a woman dies in your hands, you're liable and you'll be taken to court and to face justice. But institutions cannot object. You cannot say, the University Health Service says is conscientiously objecting to the provision of safe abortion services. No, conscientious objection is a personal conviction. Look at judicial rulings whereby the Ministry of Health violated the rights of access to the health of a woman of childbearing age by withdrawal of standards and guidelines of safe abortion, which we have worked on. Personally, I have worked on together with lots of our colleagues, thereby endangering their lives. So by banning health professionals, they were denied of their rights to information. That would help in the provision of safe abortion services as provided for by the law. Abortion as a right is allowed in cases of emergency treatment to save the life or health of a pregnant woman, and as provided by any other written law. So FIDA Kenya and 3 others won the case against the Attorney General. And that petition was of 2015, but the case was won, I think, June last year. And that girl, unfortunately, lost her life. So Dr. Ngore, when you add to our pool of research and you've published awesome literature, awesome evidence, I just want to tell our people listening that evidence is very important in collecting data, in informing people on the way forward. There's 2 national studies, 2014, Ministry of Health, led by the Ministry of Health. It was the national assessment of the magnitude and consequences of unsafe abortion in this country, 2014. And that gave us a lot of evidence to tell us that the numbers are not going down. The methods that Dr. Ngore spoke about in his qualitative, in his focus group discussions, the evidence is there. Women are using concentrated tea leaves, jik. Women are shaking Coca-Cola bottles and hoping that if you shake the Coca-Cola and put it inside your vagina, you'll be able to have a safe termination of pregnancy. These are myths and misconceptions that are further leading to loss of our girls' precious lives, girls who should be finishing university and going on to the pool of workers. Another study, 2013, the incidences and complications of unsafe abortion, a national study, Ministry of Health was involved, including the APHRC. What did KMA do? We just concluded, Kenyan Medical Association, we just concluded an analytical study on the basis of these 2 studies. And we were assisted by the Reproductive Health and Rights Alliance. And we found out that it is fact, not fiction. We have relatively higher abortion fatality rates in this country compared to other countries in sub-Saharan Africa. Fact, not fiction. This results in severe disabilities and complications that require specialized care, as well as long hospitalization periods that cost us a lot of money. These complications are due to late stage abortions because some of the girls are told, start off the process, use a coat hanger, to push it through your vagina. When you start bleeding, the nurse, the doctor will be able to help you. That is wrong advice. There's also limited provider-patient interaction, and that should aim at placing the woman at the center of care. Some of the methods and dosages for the drugs are of unproven efficacy and dangerous, and some of us are co-conspirators in this. We also see the multiple referral delays in accessing post-abortion care after unsafe abortion and subsequently fatalities and long-term sequelae. Dr. Ngore, your study is very interesting and it does show us what these restrictive and punitive laws and policies are showing us. It showed us about the negative societal attitudes towards abortion as well as gender inequality, the unavailability of the services as well as the trained providers, some of who turn a blind eye, as well as the direct and indirect financial cost. Look at this young girl who said, oh, if she loses her place at the university, she may have to look for accommodation outside. That is expensive. And it must have been an indirect financial cost that really hurt her. Our formal service providers perpetuate abortion stigmatization. This affects our younger women's access to safe abortion care. There's a lady who said that when she confided in one of us, there was information leakage. That is very sad. That is not what we expect. There's also fear that they'd rather talk to their peers, less and less to us and less to their lecturers. And they said the information from our school gynecologists should be readily available. Let's link all these things together. Let's link care of our young women. Let's link contraceptive care, cervical cancer, screening. Let's link contraception, HIV and AIDS care to abortion and pregnancy. These are all linked together. What are the challenges that we're looking at? We're looking at skills. They said, let's retrain our nurses, let's retrain our doctors. We do have updates in all these matters, but I think we must come out and say that we shall quash healthcare provider stigma because that is a capacity problem. And we must have a wide range and type of services, and we should reach our women in a gentle, non-judgmental manner. Information on sexuality, not abortion, but these two are linked. These two are linked. Let's have a multidisciplinary forum. Let's not shy away from talking to our young people. There's also personal versus professional responsibility, and there's conflict. Some of our health workers are in a dilemma. I'm a real Catholic, I'm a Christian, I'm a Muslim. Do I have evidence to provide this care? Yes, the evidence is aware. Do not turn away our young women. They will definitely go for an unsafe abortion once she has made up her mind, and we're exposing her to severe complications and death after we turn them away. I just want to say that by the time a young woman has come to you, she has sat and pondered over what she needs to do. So I just want to end my presentation by saying there are naturally some people who will disagree with these perspectives. As a people who belong to different religious beliefs, that men and women must be free to follow their conscience. What is conscience? Conscience is the final arbiter on matters of sexual and reproductive health and rights. I respect their right to disagree. Members, I respect their right to disagree. But while arguments often feel uncomfortable, they are necessary. They are necessary and indeed healthy, especially if we want our young communities to be in places which no one is afraid of the battle of ideas. We must learn to listen. Let's listen to the different perspectives in the course of sometimes a heated debate. Let's come down to the level of our young people. A simple desire to have an informed and diverse debate is increasingly the opposite of what I, as a witness, can see happening across our campuses within this country and beyond. I personally feel that restricting free exchange of ideas at the university is contrary to any teachings, whether church, whether Muslim, whether Hindu, and is contrary to the teaching of university itself. I thank you, and thank you very much. Back to you, Dr. Godia.
Thank you so much, Dr. Caro, for that elaborate and passionate presentation about the issues that are affecting young people, including our students at the University of Nairobi, and some of the challenges that they face through. Some of those challenges could be within from our side, the perceptions and the attitudes that we have towards certain topics, as you've just mentioned, including access to safe abortion and other reproductive health services. So thank you so much for also enlightening us on the key national and international documents and guidelines and technical guidelines that are available, and also some of the studies that have taken place in Kenya in the recent past, especially with regards to the magnitude of unsafe abortion in Kenya. So I would like to ask the participants who are colleagues who are part of this presentation, if you have any comment, kindly please put your comment on the chat in the question and answer section. Yeah, you can put your comments on the QA, question and answer section, and then we will read it. If not, you can also raise up your hand, and I think there's a way the team will be able to unmute you, and you're able to ask your question in plenary. So some of the questions or some of the comments that are coming in from our colleagues who have joined us in this meeting. Teresia Njoroge says that thank you for the presentation. Sad that we are still judging those seeking contraception. A good question in the questionnaire would have been if they know anyone who had a complication or even death from unsafe abortion. Yeah, so I don't know, Dr. Ngore, you can be able to respond to that, whether that is an area that was explored in terms of asking specific questions of experience of having encountered a complication or a death. Yeah, in the life experiences of the respondents of the students who participated in the survey or in the study. And so that is one. Then Diana Kemunto is saying, thanks, Dr. Ngore, for sharing your work. This study is very timely. Were there any differences in terms of knowledge on sexual and reproductive health with regards to the students in the sciences, e.g. medical school campus as compared to other students, especially among the older students. I think it's because you said that this study was carried out in 6 campuses. So we know we have the medical school campus. So if we look at information that was coming from other campuses, whether there was any differences in terms of the awareness and knowledge the students had. So I think I'll just go through the comments and then you can respond. Does UoN Health Services offer HPV vaccines to the to the young female students? This is a question from Mudoni Madai. Does the UoN Health Services offer HPV vaccines to the young female students? Yeah, I think Carol will be able to give us a response on that. Patricia Okutoi is asking, is abortion legal in the Kenyan constitution? Are there legal implications for safe abortion? Yeah, so I think Carol can respond to that based on her presentation. Then also Modoni Maldai is asking, what are the chances of young female students getting support for an early termination from an UoN health service? So now this is asking what is the current practice if a young girl comes into the UoN health service seeking safe abortion, will that be provided, or what is the current practice at the moment? Yeah, so I think we can respond to that, those few, and then there are others which I will be able to read after we've had those responses. Dr. Ongore, over to you. You can begin, and then Dr. Caro can continue.
Yes. Thank you very much, Dr. Godia. Thank you very much, participants, for those observations. Complications and death experiences, yes, this was explored, and there were real life experiences. Some of them were very traumatic experiences. So yes, there were complications and death experiences. Maybe if you read the paper, they were there. And then there were differences in the sciences, the medical. The students had a network. So the emerging theme was that the medical students tended to be consultants, in quotes, for the other students. So they would ask them, request them for information on the issues. And so it was perceived that they were more knowledgeable. So those differences were there between the arts and the sciences and especially the medical sciences. I think the rest are for Dr. Odula. HPV vaccines.
Thank you very much, Dr. Thank you, Dr. Godia. Thank you, Dr. Ongore. Yes, at the moment we are not able to, but when we do get the stock, we shall inform the community at large. And it's a very, very useful vaccine because it does prevent severe progression, but it does not mean that once you have a vaccine, then you can continue ignoring the pap smear. The pap smear is the gold standard screening method that we use to identify the early cases of changes that would lead to cancer of the cervix. As you know, that the barrier methods, we encourage our young people to use the barrier methods, the condoms, because thereby we can reduce the transmission of this human papilloma virus during sexual contact. Thank you very much. There's a question by Patricia. Is abortion legal in the Kenyan constitution? Are there legal implications for safe abortion? Thank you very much, Patricia, for that question. Like I said earlier, when you read the article 26.4, and I quote, abortion is not permitted unless in the opinion of a trained health professional, not two, one, trained professional. There's a need for emergency treatment, one, or the life or health of a woman is in danger, or if permitted by any other written law. So that is one of the grounds that we can give our women a safe abortion. Additionally, the Constitution undertakes to promote every person's right to the highest attainable standards of health. That includes the right to healthcare services. That is in 43(1) sub-article A. I talked about the Sexual Offences Act, whereby when a woman comes and says she has been violated, that is the grounds for a safe termination. I hope that answers your question. If I go to Mudhoni Madai, what are the chances of a young female getting support for an early termination from our University of Health Services? Come to us, have a discussion with us. We will give you all the options. We will not withhold any information. We will give you all the options where to go. If we're able to give you a medication abortion, that's available, that is within the Constitution. Come to us, let's discuss contraception after that. Let's discuss screening for cancer. Let's discuss HIV. Let's not forget HIV and pregnancy go together. Be open with us, don't be shy. If you're not comfortable with one of us, go to somebody else, but we are there for you. We are there to make sure you live your full potential within the health services. Thank you very, very much. I think, let me answer one more. By Metrin Nyongesa, we as medical practitioners, are we allowed to encourage abortion? And I will say this again, by the time a person, young or old, comes to you and tells you, I'm not happy with my pregnancy. You did not call them from their house. Sit down and listen. The last thing I said, let's listen to each other. Let's listen. Let's have a discussion. Let's explore all the options. Let's explore. Do not turn anyone away. We will not turn anyone away. Come, sit. Do not start drinking jig and vim and poking things. You're exposing yourself to injury and long-term sequelae, including your own death. Dr. Ngore, there's a question from Lily. Sampling method. Dr. Ngore?
Yes. This was a qualitative study, so we could not. So it was distributed among the 6 campuses. So as best as we could not be comprehensive. So it was purposive, so to speak. We went through the administration and they provided us with a list of the hostels and we selected. We tried to be as representative, as scattered as possible among the campuses. Kikuyu campus was included, Kabete, both low and upper, the business school, law school, the main campus, Chiromo. So that was the best that we could do. We ended up with 6, but scattered and tried to be as representative as possible. I hope that answers your question.
Dr. Jenro Sambuchi, hi doc. She's asking us, what is the latest position of the church on the use of contraceptives? Do you think there's a need to a friendly policy on the use of contraceptives for adolescents? Dr. Ambuchi, this is a very, 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 very difficult discussion. We can take a long time with this. You must know that people in the church are people. They're human beings. When they desire contraception, they don't come in and say, I'm a Catholic, I'm a Christian, I'm a Protestant, I'm a Muslim. They come and say, I have 5 children, or I have a boyfriend, we're sexually active. By the time you're teaching 19 to 24-year-old about abstinence, I think it's a bit late. The teachings should start at home. So the Catholic Church, as far as I know, because I am a Catholic, are open now to many, many other methods. And even the Pope said those who have procured an abortion should be welcomed back into the church. Pope Francis said that recently. We realize we live in a situation of evolving type of people, and we must try to accommodate as many as we can. I hope that answers your question, Dr. Ambuchi, but if not, I shall continue further. Owiti is asking me, if a young woman walks into my office requesting abortion services, what should I do as a healthcare professional? What should I do if the said client is a minor? And he says, religious conviction aside, if the minor is pregnant, there's two things. There's no way anyone could have gotten consent to have sexual contact with a minor. So that is automatically rape. Isn't that true, Dr. Ngore?
I believe so. No consent.
There's no way you could have gotten consent to have sexual contact with a minor. So if that is a sexual offense, then of course you can go ahead and provide the service that the minor needs. If the minor says, no, I was not raped, and they're still not happy to continue with this, we are able to offer them a medication abortion. If it needs a surgical procedure, it needs consent from a guardian, okay? I go to Asila Zephaniah, who says, when a lady touches your body without your permission, that's sexual harassment. Anybody violating your personal space is violating you, especially if they're violating your private area. Anybody violating your private space, whether you're a man, woman, man, anybody violating your private space, that is harassment. If they're touching you inappropriately, that is sexual harassment. So I'm not going to say sexual harassment is towards women only. No, it's towards either side. Even if it's a man is harassing another man sexually, that is sexual harassment. An anonymous attendee is asking us, thank you, Dr. Ngore, for your presentation. Can we teach these children the fear of the Lord? They need to know the bodies are the temple of God. If you go to the definition of children, it ends at 18. By the time they come to us at university, they are no longer children, they are adults. The teaching starts in your homes. Good people, the teaching starts in your homes. They come for an education and how to socialize and how to get into the job market. I hope I'm not too crude when I'm answering that question. Over to you, Dr. Godia and Dr. Ngore.
Just to add to the last comment by Dr. Odula, is that we have to be realistic. The teachings are there, but we have to be realistic. These people are sexually active as early as I have seen a 10-year-old pregnant. We thought this was a tumor, but when you opened up, this girl was pregnant. So the reality versus the morality, I think that is food for thought, but we have to be realistic. These fellows are sexually active. And so you need to see where the balance is. And as rightly Dr. Dula said, by the time they come to us, they're 18, not children anymore. Dr. Godia, anything you want to add?
Yeah, so thank you so much for your presentations and your answering of the comments from Dr. Ngore and also from Dr. Odula. And also for the questions that are coming in from the attendees. So there's one comment here where they're saying we talk about the options. I mean, we need to also encourage the option of adoption, just for the people who are coming to see us, also know that that option is available. And I think that is also when Dr. Odulo said, when a client comes, a young girl comes to you for a service, I think you need to sit them down together and be open and tell them all the options that are available. And I think that is one of the options that is available during that discussion. So there's just one question here, that if a student at the university is not comfortable accessing SRH services at the university, what options do they have? And do we have a way of the students knowing their options? Are there any other, is there another place that a student can go to ask, to seek services apart from the university health services, and they're still covered under the same, they don't have to incur an extra cost, I think. The issue of abortion, is abortion already legal in Kenya? That has already been answered. I don't think we'll repeat that. Some comment there from Anthony, not a question, but a comment. Religion aside, we doctors should advocate for legislation of abortion. Okay, so that is a comment from one of our colleagues there. So I think we are, I don't know whether there's any other burning issue. Dr. Ngoro, you want to relay across to your members, to the participants who are attending this webinar? Because I see we've addressed most of the questions raised. Okay, so there are some participants that have raised their hands. I don't know whether I'm able to see the ones that have raised their hands. There are 4 participants that have raised their hands. I'm trying to see how we can get to them.
Grace Kwamboka, James Musioka, Samuel Sinei, Leonard Rotich.
Okay. Can they unmute themselves and then they give their question or their comment?
I think we have unmuted them. Maybe they can raise their issues.
Okay, maybe you can call them out because I'm not able to see them from my end. Okay, I can see them.
Grace Kwamboka, I've allowed you to talk. Unmute.
I have unmuted from my end. I don't know how we can unmute them.
Oh my. Can I press allow to talk? Okay. I'm not sure how this is working, Daktari. Dr. Godia?
Hello?
Yes, Leonard, go ahead.
Yes.
I needed some help on the issue of CPD points. I've been attending, I've attended a number of these webinars, but I've not been able to get my CPD points. What could be the problem and how can it be rectified? Hello?
Yes, you had you. You had
Okay.
It's about the CPD points. I think somebody from the KNH side will be able to respond to that.
Yes, Leonard, please leave your email in the Q&A. We'll be able to contact you after that.
Okay.
I'm unable to unmute Leonard. No. James Musioka, Grace Kwamboka. If they're able to unmute, they can ask the question. Oh. Yes.
You've allowed them to talk so they can unmute themselves from. Yes.
Dr. Godia? I think they're not able to unmute, so they can type.
I think so. They can type.
Awesome.
think there's some. So someone is asking whether we can share the presentation, which is good to be shared.
Thank you, Dr. Mbogo, for listening and attending. Thank you very much.
So, Dr. Odula, there was one comment where a participant asked, what are the other options if a young girl doesn't want to attend the student health services? Do they have any other option?
Yes, Dr. Kari. The other option is any other health facility, because if they come through us first, then we can give them a referral to Kenyatta. And with the referral letter, they won't have to pay. But if they don't come through us, they'll have to go to, anywhere else, but they'll have to dig through their pockets. So it's advisable that you come to us first so that we give you the referral note. That's the way it happens. We'll give you the referral note, but only to Kenyatta. Only to Kenyatta. If they want to go anywhere else, that will be on their pockets.
Okay. Yeah, so there are options, but there are limitations. There are options, but there are restrictions. Yeah, so you can only do so much. Yes. Okay. Thank you. I think it's let's look at time. It's around 3 o'clock, so we've been on for an hour. I know it's the schedule for the webinar is 1.5 hours, but if we exhaust the discussion within an hour, we are also free to end the webinar. So in the process of planning or preparing to end the webinar, I would ask if Dr. Ongore, you have any other burning issue, last word you'd want to tell the team, and also Dr. Caro, you can also tell the participants if you have any last word before we end the webinar session.
So maybe I'll go faster. This was really investigative to find out what is going on amongst the students. And that has clearly been discussed by Dr. Dula. And as I pointed out, there is many issues that are putting our students at risk. And as she rightly put it at the beginning of her discussion, there was a time when pregnancy was a death sentence. In fact, I know of a country where when a woman is in labor, they dig a grave for her. They don't expect both of them to survive. And a lot of issues here that are putting our young people at risk are issues that are under the carpet. We do not discuss these things openly. As my colleague said, we need to talk. We need to discuss in an open and non-judgmental fashion, and we need to be realistic. As I put it, these things are happening, and being moralistic will not prevent them from happening. If anything, it will make matters even worse. So we should be as open as possible to be able to have discussion, meaningful discussion, because they are matters of life and death for these students. It came out very, very clearly that this is standing between them and their careers, and they take their careers very, very seriously. So that is the main message that I'd like to bring out, that we need to be realistic. And the young people also need to be open. One of the things that came out very, very clearly was the restrictive environment to discussing issues. Once it has happened, it has happened. And we need to make it as safe as possible, because if we don't, if we become judgmental and so on, the consequences are serious, and we have heard of these consequences. I didn't put it in my presentation, but I had very tragic experiences from the students on complications and death, where boys and girls literally saw life of somebody just ebbing away and unable to do something because of fear of judgment and so on. Then the other message that I would like, and it came out, is that our health services need to be more friendly. Let us not be too harsh on our students. These are our clients. They are our main clients. We need to be as much objective as possible, non-judgmental, and offer them the services that they require. Because if we don't, they will go elsewhere and it will be tragic. And remember, these are our kids now. It could even be your own daughter or your son. We are now all parents, and it could be your friend's daughter and so on. So that is the message that I was hoping to pass. Dialogue, let us talk to each other. Thank you.
Okay, so thank you so much, Dr. Ngore, for your last word. Carol, you have any last word for the participants before we end the webinar?
Yes. I've totally been woken up by this study by Dr. Ngore. I really thank him for doing what he did for us. Let it not sleep on the shelves, so that people have to understand what he's trying to tell us. We've really taken the message very well. I know my colleagues are in on this call, and I just want to add that, and I quoted this is Commissioner Otiende Amolo. He was the chairperson, Commissioner of Administrative Justice. He said that little is heard of the input of umbrella medical associations and societies. Unless we come out of our comfort zones and test the waters by participating in debates, budgets, other proposals, discussions on legislation, institution of strategic test cases, or securing advisory opinion on legal matters, prisoners, students, and other interest groups will run with our issues. So once a judicial interpretation has been adopted without me and your participation, or a given legislation passed without your input, you will then have to hold your peace and live with it. I am telling us members, doctors, nurses, clinical officers, let's not live in silos. Oh, this is legal. I don't want to hear anything legal. No. That's how our learned friends are running away with our issues. Let's get involved at policy level. Let's get involved at decision-making level. Let's come to the table and let's talk together. Don't say, no, me, I'm only medical. Najua kupeana sindano na tablets. No. Let's get involved in the legislative process so that all of us can move together for the sake of our young people. For our young people, I must say, the internet never sleeps. The internet never forgets. Never forgets. So once you post yourself in a compromised situation and you post it on the internet, even Instagram, it remains there for life. So by the time we're teaching our young people about God, about the church, tell them the internet does not sleep, the internet does not forget. Because by the time they're fully trained and they're out there in the world, anybody just doing a search, Carol or Dula, and you see what I posted when I was a young person, oh, I thank God, the internet was not so big those days. So let's learn that the internet is not our friend. Thank you, Dr. Ngore, my teacher. Thank you very much for this opportunity. Dr. Godia, for your work as our moderator, and all participants. Thank you very much.
So thank you so much for those last words. And the parting shot is that we need to be engaged, need to be engaged in the policy making process, in the debates and the discussion that are going on, especially where it affects our environment in which we provide services to the population, and especially the young people and our students also. So Dr. Ongore, what I would just urge you is to just look at the recommendations and see how those can be moved forward, because they are live, they are good recommendations, and if we focus on those and implement them, we'll have moved a step further. I know one of your recommendations was to maybe have a bigger study that looks at all these issues in more detail. I think that's an opportunity that we can grab and see how we can come up with a bigger study and have also more responses. The qualitative study always is good at informing a bigger and a larger quantitative study. Maybe we can do that and make use of the internet also, or the online platforms for disseminating sharing the questionnaire for our students to respond. In that, and then another recommendation was something to do with the sensitization or updating of members of staff, especially for our university health services. I think that is also something that can be carried forward. So let's engage with our colleagues and see how we can move those recommendations forward. So there, I can see on the screen there's the advertisement for the 5th International Conference on Health. The theme is healthcare and innovation in the pandemic era. So we are being encouraged to register. And if you have an abstract to submit, for students, the registration is 500, other participants 1,000. So the date's 27th October to 29th, 2021. So sometimes next week. So you're encouraged to register and share the results of the studies, any of the studies that you have. So thank you so much, and we'll meet in the subsequent webinars to come. Thank you for your participation.
Thank you, everybody. Bye.
Bye, everyone.